So we're right at 10 o'clock, so I'll start us off. Welcome everybody to the Defining and Assessing Integrated Behavioral Health Capacity. We're very pleased that you're all joining us today. This is a 5-part series hosted by the Great Lakes, Northeast Caribbean, and Northwest Addiction Technology Transfer Centers, and also the Great Lake Mental Health Technology Transfer Center. This is the first in a series of defining and assessing integrated behavioral health capacity. My name is David Jefferson, and I'm the Director of Training and Technical Assistance for the Northwest ATTC. Next, you'll see a map of the technology transfer centers in the United States. And I'd like you to know that there's also mental health transfer centers also, and they're a wonderful resource, and they're right at your fingertips, and hope that all of you are making good use of your TTCs. At the end of today, you will get an email with our survey. We'd really appreciate it if you'd take a second to answer the survey. It really doesn't take very long. In that email, you'll also get a copy of this, well, actually a link to the slides for today's presentation, and we'll also have a recording of today's presentation. As for certificates, anybody that is signed up to attend today will automatically get a certificate. However, if you're in a group and there's several people with you, please send us the names of the people in your group to the email address on your screen, northwest@attcnetwork.org. Names, email addresses, we'll make sure that the folks there get their certificates also. As for questions, we'd love to hear from you throughout the interview. I will collect those questions and then read them off to our presenters today. And we'll make sure that we try to address your comments and questions as much as possible. And next, let me do some introductions. Today we have Mark McGovern, a Ph.D. and Professor of Psychiatry and Behavioral Sciences at Stanford University School of Medicine and Principal Investigator of the Mental Health TTC Network Coordinating Office. Heather Gotham, also a Ph.D. and a licensed clinical psychologist and clinical associate professor at Stanford University School of Medicine. She's also director of the Mental Health Technology Transfer Center Network Coordinating Office. And Jennifer Harrison, Ph.D., is a social worker, chemical addiction counselor, associate professor, and interim director for the School of Social Work at Western Michigan University. We're really pleased to have our presenters here today, and I think you folks are in for a wonderful presentation. So I'll turn this over next to Mark.
Thank you. I just realized I was muted. Really grateful to be invited to share this presentation and this time with you all. It's amazing to me how many folks are interested in the topic of co-occurring disorders. We actually got interested in this many years ago, and realized that there was no standardized way to determine if a program or an organization was addressing co-occurring disorders. There was really a wide variation in what that term meant to people, what co-occurring disorders meant, what integrated capability meant, what integrated services meant. And I was based at Dartmouth in New Hampshire at the time, and was working closely with Kim Muser and Robert Drake and others who were advancing fidelity measures for evidence-based treatments for people with serious mental illness. And one of those fidelity measures was for a treatment approach called integrated dual disorder treatment, which was very effective with people that had serious mental illnesses and substance abuse level type disorders. And there was nothing really similar that existed for people that had serious substance use disorders, maybe less severe mental health disorders, who typically might present in traditional addiction treatment programs like a detox program or a residential program or an intensive outpatient program. But we knew from all of the data that the chances for people having a co-occurring disorder were really high. And we knew that there was a lot of interest in trying to figure out how to address these disorders. And we also knew that for people who were interested in using the ASAM, the American Society of Addiction Medicine approach to classifying patients and kind of organizing a treatment plan using the ASAM criteria and crosswalk, that dimension 3 on psychiatric or behavioral conditions and complications was kind of ambiguous. It was wide open. So we set forth, I believe, probably 2004, 2005, with the development of the measure now currently known as the DDCAT, or Dual Diagnosis Capability and Addiction Treatment Index. So I'm never really sure what the next slide is, but hopefully the next slide doesn't contradict anything that I said. Okay, good. So I think the plan is for us to kind of go over a little bit about co-occurring disorders. And I'm grateful that my longstanding and dear colleague, Dr. Heather Gotham, is here with me and is able to actually dive deeper into some of the detail. I think my task is really just to introduce the origins of the measures and how we develop them. But I think the importance of a measure was really as much about having a common yardstick and common language so that programs knew what it meant to offer integrated services. And you know, we think at some level that might be a very simple question. Do you offer integrated services? Do you address co-occurring disorders? And of course, in 2004, 2005, that was called dual diagnosis. Dual diagnosis was replaced by co-occurring disorders, and maybe co-occurring disorders will be replaced by complex patients where more than one condition is involved, and that would certainly fit with the rest of healthcare. But for now, we call them co-occurring disorders, and then we call them dual diagnosis. I think roughly the same thing. But back to this common yardstick concept. For instance, we thought, well, a simple question like, do you do screening for mental health problems, let's say within the context of an addiction program? That very simple question would seem like a yes or no question, but and it might seem obvious to everyone what screening is, but I can remember one conversation at actually an opioid treatment program in Indianapolis, where the answer was yes, we screen our patients. If they have a mental health disorder, we don't admit them. So that was a yes, or actually more like a no answer, but it was yes. But it's not exactly the kind of screening that we were thinking of. What we were thinking of was that there was some standardized tool, let's say the Patient Health Questionnaire 9 for depression, or the Generalized Anxiety Disorder Scale, the GAD, or something like the Modified Mini Screen, which addresses a lot of kind of a broad spectrum of mental health conditions. So that's kind of what we had in mind, but because that wasn't specified, organization could just as easily say, yep, we offer screening and we address dual diagnosis or co-occurring disorders, but has very, very little comparability with what another organization was doing. And of course, I always think about, I come from Chicago to Dartmouth and was really exposed to a lot of the points and speeches of Jesse Jackson, who's a Chicagoan, and he would say quite often that integration is not guaranteed by co-locating. So co-location is not integration. Co-location is not integration. So I think the idea there is that we knew that there were different approaches to integration, but what one person might describe as integration would be very different than another person. So we thought having a common yardstick would really sort of enable people to think about what integration actually could and should look like, and B, that if they had a standardized yardstick, that they could actually use it to see where they were at a kind of a baseline, and then use it to plan and guide, and perhaps as a map of a future state program improvement. In addition, perhaps they could see where they were relative to other organizations that were like them, and perhaps even learn from those organizations if they've already were able to make changes on the same dime or the same nickel that everyone had to work with. So please advance to the next slide. So I think most people know this, and I think the idea is that co-occurring disorders are common, that if you have them, your chances for positive outcomes are, as we say, less than average. In fact, having a co-occurring disorder is associated with a poorer outcome with respect to substance use and with respect to mental health. In traditional opioid treatment programs, we know that there's high rates of PTSD and trauma. We know those diagnoses are correlated with things like poor retention and instability. We know that a co-occurring disorder is associated with vocational and work outcomes, relationships, housing instability, costs. People that have both disorders are higher cost in terms of treatment services. And when people look at cost in terms of quality of life, also negative impact there, and greater association with incarceration and risk for suicide. So it's kind of like getting hammered on both sides. And we know that the rates are very high, and I'm going to turn the next slide over to Heather, and she can explain some of the details. This is from the National Survey on Drug Use and Health by SAMHSA. Heather, I hope you're there.
I am here, Mark. Thank you. Thanks for the intro. So this slide really is just showing us kind of what the breakdown is in this Venn diagram of people who have mental illness with no substance use disorder, people who have substance use disorder with no mental illness. And we see in that orange area that among the about 19 million adults with a past year substance use disorder, 8.5 million, which is about half of people with a substance use disorder, also had any mental health disorder. So this is clearly an important issue. And as I'm sure you've all seen in treatment settings, we know that people with co-occurring disorders are to be expected and not the exception, using the Ken Minkoff oft quoted phrase. Next slide. So we wanted to talk just a little bit about treatment options and access. Next slide. Again, what we've seen, I think, now over the past almost 20 years that Mark and I have been working in this space, is that although co-occurring disorders are common, they're seen across all kinds of different settings. And depending on where patients seek treatment, they may experience different treatment approaches, be that just mental health, just substance use, or some kind of co-located or integrated care. Next slide. We know that integrated treatment services are services that address both problems at the same time during the same treatment episode by the same providers. So as Mark said, different than co-located care. Patients who are seen in single disorder treatment or non-integrated systems have poorer outcomes. We know that integrated treatment is more effective, more economically viable versus targeting one or the other disorder independently or sequentially, as used to happen. It used to be that the mental health people would say, oh, get your go get your substance use disorder taken care of and then come back to us, and you would hear the same thing from the substance use disorder treatment services. We also know that national policy statements and guidelines and systematic reviews all underscore the benefits of integrated treatment. Next slide. Unfortunately, this is a monumental treatment gap where, although we have 8.9 million people in need of integrated treatment, only 7.4% actually receive that treatment. Next slide. All kinds of reasons for that, barriers to integrated services, many of which stem from systemically over time, the mental health and substance use disorder treatment services have grown up as separate and very siloed systems, and they continue to be separate and siloed. Even if they're located or housed in the same Department of Mental Health at the state level, they're still almost always separate. Next slide. Mark, and let's go to the next one. Mark gave a little bit of the background of why he found the need to develop these measures of dual disorder capability. And again, one of the pieces is that when we, back in the day, were asking folks, are your services integrated, that many people said, yes, of course we do that. But when you look at objective criteria, we found that people weren't really necessarily providing integrated services. So this slide shows a study of self versus independent ratings of co-occurring disorder capability. And we see that, as in Lake Wobegon, that everyone rates themselves above average. And when you look at a more objective rating, we see that programs are much less integrated than they think. Next slide. So DDCAT and the DDMUT and the BHIMC, these are 3 organizational capability measures looking at how co-occurring or integrated care can be is provided. So dual diagnosis capability in addiction treatment, that was the first measure. Then the dual diagnosis capability in mental health treatment, affectionately known as the DDMUT, and then the behavioral health integration in medical care. 3 parallel, roughly parallel indices. Next slide. The DDCAT and the DDMUT both have 7 dimensions, 35 items. Here's a brief snapshot of what the different dimensions are and the content. So that first dimension is program structure, and it focuses on general organizational factors that foster or inhibit the development of integrated treatment. Program milieu looks at the culture of the program and whether the staff and the physical environment are receptive and welcoming to people with co-occurring disorders. The third and fourth dimension, referred to as the clinical process dimensions, look at whether specific clinical activities are integrated into the program. The fifth dimension is continuity of care, which examines the long-term treatment issues and external supportive care issues commonly associated with co-occurring disorders. The sixth dimension is staffing, looking at staffing patterns and operations. And the seventh dimension is training, the appropriateness of training and supports that facilitate the capacity of staff to treat people with co-occurring disorders. Next slide. Each of the items is scored on a scale from 1 to 5, where 1 represents addiction or mental health only services. These are programs that serve clients with no or minimal co-occurring disorders. DDC is a 3, and that's dual diagnosis capable, and these programs serve clients with low severity co-occurring disorders, not high acuity or high severity. And then DDE, dual diagnosis enhanced, or what we'd consider a fully integrated treatment. These are programs that serve clients with more severe and unstable co-occurring disorders. Next slide. As we kind of circled around this idea, we know that when programs rate themselves, they often score much higher than when they're rated by independent outside objective raters. So the methodology for these indices is to obtain ratings based on independent site visits conducted by external raters. Typically, the site visits are half-day visits, and they cover a variety of sources, ethnographic observations of the milieu and the physical settings. You know, what does the waiting room look like? Is there information on both substance use disorders and mental health disorders in the waiting room, and things like that in the physical setting. Focused but open-ended key informant interviews with agency directors, clinical supervisors, clinicians, prescribers, kind of all the folks, including the clients. I know Mark is fond of saying if you've spent more than about 10 minutes talking to the agency director, that you've spent too long, because we really want to find out from the clinicians themselves, from the frontline staff, and from the clients, what's it like to be, you know, treated in this setting. And then review of documentation such as medical records, program policy, procedure manuals, brochures, and things like that. Again, trying to look at what are the things that people are recording and paying attention to. Again, the unit of analysis with the DDCAT and the DDMUT are, it's at the program level, right? So not at the agency level, because we know that even within agencies, different programs can have a different level of capability or capacity to serve patients with co-occurring disorders. And we're always looking for this triangulation of data. So this gets back to my comment about sometimes you will see differences between what agency directors or clinical supervisors say versus what the clinicians or frontline staff perceive. You know, I've been to a number of clinics that if you ask them about things like, you know, are you using motivational interviewing? Of course, the directors and clinical supervisors may say yes, but when you ask the clinicians, they might say, well, we received a training on it, but I don't feel like I'm really competent to provide that service, or we use it, but only to some extent. And the clients might have a different perception as well. Not that anyone's necessarily, you know, wrong or, you know, trying to sway the ratings on purpose, but we all have different views. And it's really important to understand kind of where everyone is coming from in order to get a whole picture of what the services are really like. Next slide. This is an example of the results that one gets from the DDCAT or DDMUT. It's a summary profile. So this is an example community addiction treatment program in Washington State. And a typical report will have a graphic like this showing where the site is on the different dimensions of the DDCAT or DDMUT, as well as some accompanying information about why the score on each of these dimensions. The 35 items are summed, and we get the mean across each of the dimensions, and then a total score. So in this example, we see that in this center that there are a number of dimensions on which the site is between dual diagnosis capable and dual diagnosis enhanced. We see that continuity of care is a little bit lower. So they're below the dual diagnosis capable. Staffing is quite high. They're at an integrated level. Training is a little bit lower than that, but still fairly high. And the beauty of this instrument then is that this type of report can lead to very concrete real-world steps that an agency or program can take to increase their capability. And we will, you know, follow along with each of the items and how they're rated, and then be able to provide suggestions for how the program or organization can change. Next slide.
Heather, could I jump in on,
Sure.
on that? And I don't know if we can go backwards on the slide deck. That might be a formidable. Oh, excellent. Thank you. So this is a really, and because we've done, I don't know, thousands of these, we have kind of gotten used to looking at these profiles and how to interpret them. So as Heather mentioned, these are the 7 dimensions, and the dots are the average score for that particular dimension. And this one is interesting because you'll notice that the staffing dimension is way at the top. It's dual diagnosis enhanced, which sort of means that the staffing, the people who work in the program, are at the dual diagnosis enhanced level of capability. but the services they provide aren't at that level. So not to be use a label of underachieving, but this is a program that has the potential, based on the qualifications and training of the staff, to deliver much more integrated services. So, I mean, the good news is they have the players, and I guess the opportunity is here for these players to to play up to their potential with perhaps a better program design. And the DDCAT or DDMUT can really enable them to understand what that means. It kind of gives them the game plan, if you will. There are an equal number and maybe even more programs that have staffing that are even below the DDC, perhaps closer to the AOS, and they actually sometimes deliver really nice integrated services. In some ways, they can be overachieving programs because they may often exceed what you might think of as their kind of licensure or scope of work. So just being able to think about where the staffing are, where that sort of average is, that bullet point, where program structure is, because that might have to do with licensure and certification and mission, what you get paid to do. Keeping an eye on those two is often really important to think about where you stand with respect to the actual services you're delivering. So I'm sorry to interrupt, Heather, but I wanted to introduce people to the ways to interpret a profile.
Mm-hmm. Excellent. I see we have a question about what prevents these dual diagnosis enhanced staff from performing at the dual diagnosis enhanced level.
Well, I think that the answer to that is could be complicated, but in some respects, it might mean that they didn't know what it meant to deliver these services. So the DDCAT and the individual items could give them some ideas about what it means to deliver integrated services that they weren't previously aware of. So sometimes it's just about getting the information about what it means to deliver and how they might deliver integrated care. In other situations, there may be barriers, for them to do it, and sometimes those barriers could be attitudinal. There may be stigma associated with mental health issues. I remember one treatment program in Connecticut where one of the patients said that he dare not bring up that he had mental health issues because if he did, he'd be kicked out of the program. This was a residential program. And another patient I interviewed in Austin, Texas, who was a nurse, said, it's okay to have certain kinds of mental health issues, but it's not okay to have other kind of mental health issues. So sometimes it's the tradition of the program that can kind of get in the way, around attitude and stigma. And sometimes it's really about just not being aware of the kind of things that people could do clinically to deliver more integrated care.
Great, thank you. I'm sure that Jennifer in the next section is going to have some great examples of how this works in the real world as well. So I think that's also a great segue to talking a bit about the DDCAT and DDMUT toolkits. These are two larger resources that were developed through some funding from SAMHSA. They're published in 2011, but I think they are just as applicable now as they were then. And so these really take the two tools and expand them. The toolkits provide information about applications for different purposes, about methodology and training, kind of going over more specifically about how do you learn how to do the DDCAT and DDMUT, how to do scoring and profile interpretation. And I think one key piece that was just alluded to in that question was about how do you enhance, how do you move from addiction-only services to dual diagnosis capable or dual diagnosis capable to dual diagnosis enhanced. And for each item, each of the 35 items, there is an example of how to move from AOS to DDC or from DDC to DDE that provides, like I said, a real-world example of concrete things to do. And programs find that really helpful. There's also information if you're performing a site visit about how to do that. There's sample forms and some screening and motivational tools. So we'd really suggest folks turning to those toolkits to get a better appreciation for the tools as well as those keys about how to enhance and move your program forward. Next slide. So I hope you're getting a sense of kind of what the tools are and how they can be used. We often use them as an assessment method at baseline and then as a measure of change over time. So with the previous graphic, we could go back to that same program and assess them in a year or 6 months or a year and a half or 2 years, put another line on that graphic and see how they've changed. A single agency can use these as a quality improvement process. They can be used through a formal implementation and change plan. We can have a large-scale state system change. So states have implemented the DDCAT and the DDMUT at the state level and have done improvement projects across the state. And they're also used for formal implementation sciences and health services research. Next slide. So this is an example of using the DDCAT in research. This was a project that was recently completed looking at increasing co-occurring capability in addiction settings using the NIATEX model. So NIATEX out of the University of Wisconsin, the Network for Improvement in Addiction Treatment. In this study, we looked at 49, I should say Mark and colleagues looked at 49 addiction treatment programs in Washington State and looked at the effect of providing NIATEX process improvement strategies, individual coaching, and peer sharing with other agencies, and saw that there was an increase, significant different increase in those sites that use the NIATEX strategy. Next slide.
Heather, before you leave that slide, I had another observation, and I think this is really unfortunate at some level, but it's really magical on another level. And what Heather said is true, that by partaking in NIATEX and using NIATEX process improvement strategies, organizations in that arm of the study, if you will, were able to make more significant changes over the course of 1 year using the DDCAT and a NIATEX coach. But if you look at that red dotted line, you'll also see the waitlist group make pretty significant changes as well. Now that's kind of like, because it was our study, we were kind of thinking, well, that's not exactly what we were hoping to find. We weren't hoping to find the control group, if you will, did almost as well as the experimental group. But what does this mean? Well, it means that sometimes if you have a measure like the DDCAT, it gives you great information about what you need to do to improve your integrated service capability. It's someone once said to me that it's like having the answers to the test, that if you scored at a 2 or a 1, you see on the measure what it takes to score a 4 or a 5. So we now call this waitlist group kind of enhanced feedback and monitoring, where they can actually use the information to make the changes. So we had many organizations in that waitlist arm that basically took the information and ran with it. So it was really kind of awesome that all programs, whether they were in the active NIATEX group or in the waitlist group, got better just by virtue of having the information from the DDCAT. So it's just a point that was a little hard to stomach as the research people on the project, but the good news is that everybody got better, whether they got the experimental support or not. Sorry to interrupt again, Heather.
No, thanks. That's great. And I do think, and this is I think next slide is our ending. The ending music is coming in for us as we turn things over to Jennifer, but just want to reiterate, as Mark said in the chat, the toolkits really are a resource to help agencies increase integrated care with zero additional funding. The most of the examples of moving from AOS to DDC, DDC to DDE are low cost or no cost examples. And we're just happy to have people use them. This is all free materials, and we're happy to have them out there. So we'll turn things over to Jennifer.
All right, great. Well, thank you so much, Mark and Heather. So as we talk about co-occurring fidelity implementation, and in particular states or regions. One of the things that I want to talk about is really using, as Mark talked about, that common yardstick to apply to different programs so that we can really lessen, Heather talked about that monumental treatment gap, right? We know that people with co-occurring or complex disorders are not getting the level of dual disorder enhanced or the level of fully integrated care, which is same time, same team, same place care that they deserve to get. And so we're hoping to make sure to do that. So in the state of Michigan, we have developed a team called the Michigan Fidelity Assessment and Support Team. It's the MiFAST team. We originally talked about developing us as just the Michigan Fidelity Assessment Team, but that's just MiFAT. So we just wanted to be speedy as well as chubby in our approach to evidence-based practice implementation to help serve our folks with the best evidence-based practices in an appropriate way. So we'll go to the next slide. So I'm really talking about not only the importance of treating co-occurring disorders in an integrated way, but ways that in our state we've used the DDCAT, the DDMUT, and other tools to measure fidelity to gold standards of evidence-based practices. And then more importantly, as Mark and Heather talked about, to really move individual programs forward and to give them those answers to the test so that they can decide programmatically what their next work plan foci will be to move themselves forward in ways that are meaningful and are measurable to them. So the next slide. So this is all about translational research, right? I think one of the things that I often talk about in my teaching and in my research is that we can think that evidence-based practices or these fidelity toolkits are somehow created from on high and handed to us on stone tablets. And what we really know is that good clinical practice wisdom leads to these research questions like, what does it take to have a dual disorder capable or a dual disorder enhanced program? And that when you do the research, like Mark and Heather described with the NIATEX project and with really the development of the tools available for the Center for Evidence-Based Practices, then you have the answers to those questions, but we still have the task of translating that research into something that we can use in practice. So I sometimes say that it's like the Schoolhouse Rocks, how a bill becomes a law. That, we start out with I'm just a bill, I am only a bill, and I'm sitting here on Capitol Hill, and then go through these iterations of steps of how do we go from clinical practice wisdom into research and analysis, and then translate that back into further clinical practice wisdom so that we have both evidence-based practices and also practice-based evidence that we're using in our fields. So next slide. So I'm sure that probably most of you are familiar with this 4-quadrant model for treating co-occurring disorders, which is that we know that even amongst people with co-occurring disorders, like for instance, if we're talking about dual disorder capable services, that those are for low intensity individuals with co-occurring disorders, generally are quadrant 1 individuals, and that quadrants 2 and 3 have either a high intensity, high acuity, high severity mental illness in quadrant 2, or a high intensity substance use disorder in quadrant 3. And then we also have our quadrant 4 people who have both typically a serious mental illness as well as a severe substance use disorder at the same time. And we know that the outcomes for individuals are worse, and the treatment engagement is worse the higher you go in terms of this 4-quadrant model. So certainly quadrant 4 individuals deserve more intensity of services, deserve those dual disorder enhanced services, whereas quadrant 1 individuals are probably okay with just dual disorder capable services. Okay, next slide. And then these are some of the, these are some of the tools that we use. So in MiFAST, we use the DDCAT and the DDMUT. We also use the integrated dual disorder treatment and assertive community treatment fidelity toolkits designed by SAMHSA within our process. And this is kind of where we locate them within those 4 quadrants in our state. So next slide. Yeah, so we talked about, why are we implementing evidence-based practices? That there's some efficiencies related to lower costs, but really more importantly related to better outcomes for the individuals that we serve. We certainly want to increase the awareness and build capacity for our systems on the importance of identification and treatment of co-occurring disorders. Also that we know that early detection and treatment improves the outcomes and the quality of life for people with co-occurring disorders. So those are some of our, I guess, philosophical underpinnings of, you know, why is all of this measurement worthwhile for us as practitioners or as program leaders. Next slide. And just that I know that Heather and Mark talked about this, but I always think about in my clinical care as well as in my research, what diff am I making in the lives of people with chronic illnesses, including substance use disorders and mental health conditions. So how am I helping them to impact the duration, intensity, or frequency of their symptoms, which also have a significant impact on their outcomes and quality of life. And if I'm not impacting that diff, then I'm probably not putting my energy in the right spot. The next slide. So we found that the successful implementation of our co-occurring disorders occurs at different levels. And again, we talked about this, Mark and Heather talked about this previously, that states and regions need to provide clear policy directives with consistent organizational and financial supports. I know there were some questions about, you know, how do we do this with segmented or siloed funding? And that's where I think our state or organizational levels really have a role to play, help at least braid, if not unsilo, those funding streams. That our program changes are needed to incorporate the mission to address co-occurring substance use and mental health disorders. So if you have an organization, which Heather talked about, we've kind of grown up differently. If you grew up as a mental health practitioner or organization, then your old mission might have been to just serve people with mental health conditions. And it might have actually almost explicitly excluded people with co-occurring substance use disorders. If you're from an addictions only treatment provider traditionally, then again, you might have almost exclusively excluded people with co-occurring substance use disorders. So really looking at the mission, vision, and values of organizations, that they are intentionally treating people with co-occurring disorders, and that's actually one of the items on the DDCAT and the DDMUT. I'm kind of referring to these as the DDCAT and the DDMUT, and you'll see that the old name for the integrated healthcare setting was the DDCHICS. So we always joke in Michigan that we had the DDMUT, so we had the dog, we had the cat, and we had the bird as our different levels of measurement. So at the individual clinician level, we want to support the acquisition of expertise. And then we also, and this is really critical, we want to make sure that there's accurate information about screening, about assessment, about treatment availability, and about anticipated outcomes to consumers and family members, in terms of we're asking our consumers and family members to buy into participating in evidence-based practices. And the reason why we're doing that is because it offers improved outcomes over our treatment as usual. So we need to describe that process. We're not just doing it to kind of advance our own learning or to experiment on people. It is only because this is associated with improved outcomes, which means real quality of life improvements for people with co-occurring disorders. So that's the reason why all of us are doing this as practitioners. Next slide. This is some of the estimates of population with co-occurring disorders throughout the state of Michigan. The adult population is just over 7 million. Those with a serious mental illness is just over 300,000. Those that are served within our public mental health system is 236,000. And those with a co-occurring disorder within a given year, which is 2016, is about 71,000. Next slide. Yeah, so this is kind of some of our timing. You know, we started planning in around 2004. I'm not sure that it took us until 2004 to really recognize that there was a problem with our treatment as a state of co-occurring disorders, but that's certainly when we developed more integrated planning on how to address this problem with implementation. We started using the DDCAT, the DDMUT, the IDDT and ACT toolkits in the MiFAST team in really 2006 to 2010, and then since 2010 have been in a process of continuous quality improvement with those processes. Next slide. Yeah, so you know, we, like every other system of care, like every other state, have challenges to evidence-based practice implementation. We've still have some separate funding stream issues. We have services that are defined by diagnosis. So, you know, you have to have a diagnosis of a major depressive disorder or a psychotic disorder to get in the door with this program. Or if you have this other diagnosis, you're excluded from this program. We still have some times where individuals with co-occurring disorders can't get all their services in a fully integrated setting. That we still struggle with traditional either sequential or parallel models where people can't get all of their service delivered in one location. And we're still really working to collect the scope of our co-occurring disorders. So even to measure the number of people with co-occurring disorders, we have some reasonable estimates of that, but we're always looking to get better with that data. Next slide. So this is kind of our process in the state of Michigan. So, and I won't go through this much, just to say that it's multi-step. So you don't do this all at once, but glad to consult with anyone about steps that they can take within their own state systems. Next slide. Okay, so next slide. So I talked about the Michigan Fidelity Assessment and Support Team. So this is how the MiFAST team works. A site or a program or an organization would contact MiFAST and say, you know, we're looking to get better at co-occurring disorder services or trauma-informed services or assertive community treatment. And we would schedule a one-day review with MiFAST team members who are all trained in the implementation of these fidelity toolkits. The team member would schedule with a particular program or organization a one-day review that would include several different reviewers. We developed the structure for the review day together with the team. So Mark talked about the different, and Heather talked about the different triangulation of data. So we would do interviews with the clinicians, and we would look at the electronic health record, and we would go out and meet with consumers or clients and their families, and we talk to the administrators, and we check out the stuff that's up on in the lobby walls, and we would look at the mission, vision, and values of the organization, and we'd ask, what do you do if somebody is discharged to the community and runs out of medicine? So so there's a series of things that we talked about, and then we use that to develop the report. So similar to the chart or the line graph that Heather and Mark showed us, we develop a full report that has all of the scores and has those mean scores for each of the 7 categories for the DDCAT and the DDMUT, and then also has key strengths and then recommendations for improvement of each item within each category. And part of what that's used for is it not only is a report of the review of the DDCAT and the DDMUT, but it also acts as a work plan. So we've got a space with each of these categories of items where teams can use from baseline to next review to 3rd, 4th, 5th review, can use this as a work plan within their organization to help them to move incrementally forward. The other thing that we work to do is to talk about how, by doing the fidelity review on whatever practices you're working on, that helps you to access training, consultation, and coaching to move your processes forward, and that all of that training, consultation, and coaching that is recommended in the fidelity review is available to the program free of charge as part of a block grant funding. All right, so next slide. So we really talk about that our approach with MiFAST is all carrot and no stick, that we are providing consultation and training free of charge after the review. The team can decide where to focus energy on improvements after the review. You probably can't focus on every single item, so you're going to decide where the juice is worth the squeeze in terms of your work, and that the MiFAST team members are available for ongoing consultation and fidelity reviews for any teams at any time. So we really work as lead reviewers to establish an ongoing relationship with our program leaders so that we can be available as resources to them on an ongoing basis as they have a sticky issue that they're dealing with. So I feel like that approach of all carrot and no stick is critical, in part because programs also have the experiences of audits or contractual reviews where the follow-up is a corrective action plan or the follow-up is a money clawback. We have intentionally at MiFAST kept ourselves very separate from the contractual and funding apparatus that is in place in the state of Michigan for Medicaid dollars so that we can have merely a peer review that's a point in time analysis and a report. Go ahead, next slide. Yeah, so these are some of the how we've really been able to push some of the implementation of key evidence-based practices in the state of Michigan, in part by encouraging this fidelity review process. So next slide. So one of the things that we found is that our teams are often implementing multiple evidence-based practices simultaneously. So in addition to working on co-occurring services, they're also working on trauma-informed services. They may also be implementing biological behavior therapy, individual placement and support, for supported employment, motivational interviewing. So we can provide all of these reviews as standalone reviews. We can also combine reviews into a single day. It's still several different reports that programs or teams are issued, but in this way, whenever you have a review, your team has to kind of stand down for a half day to a full day. And so in this way, we at least make it more efficient in the process so that we can bring in the reviewers that we need with the expertise that we need them. We can complete all of the reviews. A lot of the data we can really use on multiple different reviews, and then we can provide the number of reports that the program or team needs to be able to use for their own quality improvement and further development. So next slide. Yeah, so certainly welcome. I know I was having a hard time following the chat while I was talking, but David, if you can go back and ask us some of the questions, then we would just love to hear about all of your experiences, as well as questions that you have about implementation of co-occurring tools.
Great, thank you. I have gathered a few questions. I noticed that there's been some light answers to them, but maybe you folks might want to elaborate. One in particular that came up early on, have you seen better results today with the DDCAT? Anything else in particular you want to say about that?
Is that to me, David?
It just was a general question early on when Heather and Mark were talking. It says, have you seen better results today when the DDCAT was initiated?
So this is Heather. My original response to that in the chat was, I know during the 2000s, we did a number of studies in Missouri, specifically looking at some targeted sites, and then looking at the whole state, and saw that over about a 7-year period, the average level of capability in addiction treatment programs in Missouri did rise. So I said all boats rise, but still, even by close to 2010, was not at the capable level. So I know we've seen other programs. There's a huge program in New York State around the same time, where they were looking at trying to get all sites up to the capable level. So it'd be really interesting to know in this day and age and era, what kind of the baseline average is over the country. But I suspect there are still very many programs of both kinds that are at the addiction or mental health only services level, or maybe between that and capable.
So I would maybe answer that with a little bit more of the glass half full interpretation. I do think that collective waterline is higher now than it was 10 years ago. I guess the word's out, that people with mental health conditions have substance use problems, and people with substance use problems have mental health issues. And my sense is that there, at least in the work that I've seen across states, that there's closer to dual diagnosis capable on average than there was a decade ago, which I think is really terrific. I mean, it's not quite at the level of trying to find a physician who's prescribing high doses of opioids post a very simple procedure. That's been a more mammoth societal change, but I do think it's also true, and to agree with Heather on this side of it, that there's still a great opportunity to increase the integrated services, because we know that there's been no reduction in patients with co-occurring disorders. If anything, maybe that number's gone up. at least our capacity to detect it anyway, because we know that the National Household Survey information is probably just the tip of the iceberg to the scope of the rates of co-occurring disorders that are out there. And it's even higher amongst patients who are actually seeking treatment. So I guess it's a glass half empty, glass half full response.
Yeah, and I'll just kind of add, you know, that which we measure, we improve, right? So when with using the DDCAT, the DDMUT, and other fidelity tools provides you with that common yardstick so that you can know your point in time evaluation, and then also get ideas on what to do about that, on where to focus your energy, because we can't focus our energy on everything. So we have seen that using the DDCAT, the DDMUT, has helped teams to improve their scores over time with external review. And like Mark and Heather talked about, that same significant improvement is not seen with just a self-review process, because we all feel like we're in the top quintile of services and we don't assess that well for our own programs. So I think the use of an external tool and the use of external reviewers is key to those overall improvements over time.
Well, along the same lines, there was one, and Mark, you answered this one a little bit, but the person said, can we talk about how to integrate substance abuse treatment into the mainstream medical facilities? What more you want to say about that?
Yeah, I think that led to the, you know, the the evolution of these measures is kind of interesting. And you know, the DDCAT was the first one, but then we heard, well, that's for addiction treatment programs. What do we do if we work in a mental health program? So then that led, and this led Heather and her team in Missouri to develop the DDCMHT. But then we heard from people in federally qualified health centers and medical clinics. Well, what do we do about our site? Can we, you know, can we use the DDCAT, or can we use the DDMUT? And we said no, but they did it anyway. And we realized that maybe we needed to create an alternative measure that was really specific to that context. So I think that was circa 2010, and the measure has evolved considerably. What's typical is that medical care sites will, and they're actually now required to screen for depression, screen for tobacco, screen for alcohol. And just recently, there's been some new preventive task force guidelines around screening for drugs. So a lot of the primary care and FQHCs are interested in integrating mental health, and now more recently services for substance use patients. I think what's been interesting, a side effect around the opioid epidemic, is that more medical providers have gotten involved in the treatment of substance use disorders because there's a medication that's available. So I think that the level of readiness is much better now than it was years ago, as many people have struggled to implement SBIRT within primary care type settings. So it's a good question. It's a great opportunity. The measure to use is the BHIMC, which assesses both the degree of integration of substance use and also the degree of integration of mental health services.
Okay, great. And, you know, folks, we're kind of getting close to the end of time here. And so I thought I'd do a little housekeeping, and we'll collect the questions, and maybe we can kind of put these together and see if there's some things pending at our next event. So in the chat box, there is a click to fill out our survey. And our next presentation is on July 30th. And it's best practices for co-occurring disorders treatment, organizational structure, and service environment. And we'd love it if you folks would join us for that next one. And I'd like to say a big thank you to Mark, Jennifer, and Heather, and Meg, who's behind the scenes running the slides. Thank you all very much for a wonderful presentation. And to all of our folks that have joined us from all over the nation and even overseas. So thank you all for attending today. Anything else from our speakers?
Really grateful for everyone's participation. And wow, Michigan is really taken the lead. It's awesome to hear about what's happening in Michigan. So congratulations on what sounds like a transformative, really kind of innovative work there. It's great to hear about that.
Yeah, we're certainly working hard, and it's I think it's all of our practitioners and our clients and our peer support partners and recovery coaches have really been key in terms of thinking about how to continue to make our systems more more evidence-based and more recovery focused in the work that we're doing. So gracias por todo, for everyone for attending, and really appreciate all of your time and attention today and the work that you're doing every day.
Thanks, everyone.
Okay. Bye, folks.